Thank you, Dr. Lalit Verma, for inviting me for this team talk. It's always a pleasure to come and talk, especially in India. So I'll tell you about my experience and what we do back in the UK. So I'll start. I had put a lot of slides, but I'll try and keep it very relevant to how we manage. So just to start with, I don't have any financial disclosures, and I have divided my talk into these categories. So I'll skim through the latest evidence base and then talk about the practical aspects of how we treat patients with diabetic macular edema. So going into the pathogenesis slides, we know the present treatment tackle the later stages of the pathogenesis pathway. However, it gives us opportunity for further future research where we will probably have some sort of combination treatment or specific treatment which tackles early in the pathway. Now, talking about the laser, which has stayed the pivot, the mainstay of treatment over the last more than 30 years, which still has a role, and at the moment we would recommend using this form of treatment for non-center involving diabetic macular edema. So a patient who comes to my clinic who has the clinically significant macular edema based on EDTRS criteria, for example, this patient, I would start them on laser and not necessarily do a fluorescein angiogram, which we tend to do in most of the cases, but also do a baseline OCT and color photographs. Now, this is a useful guide. So this is the Royal College of Ophthalmologists has published the latest guidelines, where you can see in the conclusions, in the next slide, that the gold standard for treating center involving diabetic macular edema has changed, and now it's anti-VEGF therapy. And the reason for this shift is the limitation of laser treatment for center involving diabetic macular edema. Now, we knew that it reduces the risk of moderate visual loss by 50%, and we also know in 20% of cases we get about 10-letter improvement, and this is based on the drcr.net study with laser versus IVTA published in 2008. However, the limitations are you can apply a limited number of retreatments. Also, when there is significant macular ischemia, you would worry about making the patient's vision worse. Also, you can't laser close to the foveal avascular zone. So I'll go through the phase 3 trials and just emphasize on specific data based on which how we manage center involving diabetic macular edema has changed. So one of the phase 3 prospective randomized clinical trial, which was multi-center, was the RESTORE study. And the RESTORE study had 3 arms, as you can see on the slide. And one of the arms was ranibizumab only, one was the ranibizumab with laser, and the third was the sham arm with laser only. What you see is 40% of patients, they gain about 10 letters, and about 23% patients get more than 15 letters improvement. So what you're seeing is you have a treatment which has 2 to 3-fold better result than laser treatment for center involving macular edema. The other important thing to remember is more than 95% of the patients are stable in terms of less than 15 letters loss in vision, which I'll show you the figures, but with laser you have more loss of vision compared to anti-VEGF therapy. Now this slide I have put, it shows the reason for rationing treatment in the NHS, which is free of cost. So one of the criteria, although in practice you may consider treating any patients over thickness of 300 microns, but the actual, in terms of cost effectiveness, people who have more than 400 micron thickness, they have more beneficial effect with anti-VEGF. The RESTORE study, we have the data from the RESTORE extension study, and that's the 3-year data, and what it shows, the initial gain in vision you get is maintained. The other trend, what you're seeing is the number of injections, it tends to go down. So it's the first year where you require more number of injections, and then to maintain that stable level of vision, the number of injections goes down. And what you're finding is the number of laser sessions you need to do. In some of these trials, it was given as an option, as an add-on after the 3 months or 6 months down the line. So the Restore Extension study, what you find is at the end of 3 years, you have even more stable maintenance of vision with gain of more than 10 letters in 45% of cases, and more than about 29% 15-letter gain. And the number of injections is about 14 injections over 3 years. The drcr.net study had 4 arms, and they had it was slightly different. And one of the downsides was the complex treatment protocol into the second year of treatment. And what it showed is the deferred, so you start with anti-VEGF, and it had 2 arms. One was with prompt laser treatment, and the second arm was deferred laser treatment, when you start the laser treatment only after 6 months. And there was the third arm, which was the triamcinolone and prompt laser, and the fourth arm was the sham laser arm, laser with sham injection. So what you find in drcr.net study, and that's the only study where we have the longest data, so I'll show you the 5-year data. And what you're seeing is the deferred laser arm and the prompt laser arm, they actually score better. However, in the triamcinolone, in the subgroup analysis, in pseudophakic patients, you may get equally effective result. However, you can see the laser patients, they don't tend to fare very well. So to say again, at the end of 2 years, they found 48% gaining 10 letters, 29% gaining 15 letters. And the same at the end of 3 years. One of the things I want to emphasize here is the difference between the prompt laser, so ranibizumab with prompt laser. What you find is at the end of 3 years, they require less number of injections. However, in the deferred laser arm, they require slightly more number of injections, and they have better visual gain, which is about 2.4 letters at the end of 3 years and about 2.6 letters at the end of 5 years. This is a slide showing the 5-year data, which has recently been published. And what you're seeing is in the 4th and 5th year, the number of injection goes down, and only around 50% of the patients require treatment of 1 or more injections down the line. This slide shows that actually in the deferred arm, so where you are not lasering the patient initially, you may actually get away without doing any laser treatment, and 56% of the patients did not actually require any laser. So this is the 5-year data, which you can see both the deferred laser and the prompt laser, they fare equally well. So one of the things you see from both these studies is how the anti-VEGF treatment is more effective with giving you better visual gain. Now the third study is the RISE and RIDE data, which I have put here, and this study was done comparing the ranibizumab 2 doses. So and the reason is which is the reason for having it licensed. So you have 0.3 milligrams, which is licensed in the US, whereas in the UK it's the 0.5 milligrams, which is licensed. And in this RISE and RIDE study, they had monthly injections over the 2-year period, and there was a sham arm. However, they found encouraging results, and the patients in the sham arm were actually offered injections much earlier than the scheduled 2-year period. And what you see is more frequent the number of injections, you get probably slightly more. So where you were averaging around 10 letters, you are getting about 12 to 14 letters improvement in vision. So at the end point of the RISE and RIDE study, at month 24, you find 42% of ranibizumab treated patients actually gain 15 letters ETDRS from the baseline. The other interesting parameter which we are recognizing is the alteration of the diabetic retinopathy status. And anti-VEGF actually modifies the diabetic retinopathy in these patients because of downregulation of the VEGF inside the eye. The aflibercept, which has recently been licensed both by the FDA and in Europe by the EMEA authority, is going to again give an alternative treatment strategy where what we find, just like AMD patients, the 2Q8 arm, so where the patients in this trial had 5 loading doses and then they went on to 8 weekly injections, they fared almost same as people who had monthly injections. So this is a slide which is just summarizing the different trials, the pivotal trials, the phase 3 trials, and what you're seeing is almost with anti-VEGF injections, with or without laser, they have about anywhere between 10 to 12 letter gain. And patients where you started with lower level of vision, they tend to stand to gain slightly more. Now this is the most relevant bit for us because all the data from the trial is good and we can base our treatment strategy. But what you have to tell and when you have real life situation. So just to summarize, like laser still you would do for non-center involving diabetic macular edema. The combination treatment which we expected from the pivotal trial, combining laser with anti-VEGF injection, actually doesn't give you that additive effect. And maybe deferred therapy with laser and starting with anti-VEGF is a better option. However, what we don't know is if there is any long-term beneficial effect of laser for beyond 5 years. We are yet to see that data. So I'll not concentrate on this. Bevacizumab, this was a Moorfield study done by my colleague Phil Hyken, and it was a well-conducted study, but it was a small study and gave similar results to ranibizumab.
Dr. Paul, can we summarize, please?
Sorry?
Can we summarize?
Yeah, sure. So this is the summary slide on Avastin, and what we found in this study, so it was only 80 patients, and they were divided into 2 groups. So one group had Avastin 6 weekly and 3 loading doses, and then they went on to PRN injection 6 weekly, compared against laser treatment which was done every 4 monthly. And what we found was a median improvement of 6.5 letters, and 50% of patients, they gained more than 10 letters, and about 30 to 40, over 30% gained 3 lines. So it's pretty much comparable to the ranibizumab. The other important thing in this study we did was looking into the foveal avascular zone, and it was reassuring that there was no enlargement of a foveal avascular zone over a 2-year period. Vitrectomy, I think the role of vitrectomy is mainly in patients where there is ERM, and also if the patients have vision of less than 624. So you have to be careful offering vitrectomy for. This is a synopsis slide, but which is the Royal College of Ophthalmologists published guidance, and it's very helpful, but it's too detailed, so I won't go into that. Coming on to the main bit, which is the practical aspect. So the practical aspect are the principles of treatment with anti-VEGF injections for center involving. So patients who have vision of less or equal to 6/9 but more than 4/60, the foveal avascular zone which should be less than 1500 microns. Otherwise, you're treating patients with macular ischemia, and we are not sure how they will fare. There shouldn't be any structural damage to the fovea, like fibrosis. If there is proliferative diabetic retinopathy, that needs to be treated first, or at least you have to start the treatment, and once you're happy with a couple of sessions of laser treatment, you can go on to anti-VEGF treatment. I think the important thing is to emphasize that it's not a one-off treatment, and the patients are looking to 3 years or beyond of treatment. So you have to tell the patient that they are looking at about 8 to 9 injections in the first year, which goes down to 4 to 5 injections in the second and 2 to 3 in the third year. And at least 50% of the patients are going to need treatment beyond the 3-year period. Our strategy is to defer the laser treatment till the macular so based on the previous studies and the positive data which we have found, so we defer the laser treatment to until 24 weeks. About 1/4 of the patients will have both the eyes being treated at the same time, so they will be having injections bilaterally. Also, you have to, patients with macular edema, you have to look into the whole eye and not miss any proliferative retinopathy, which needs to be treated. Also, you can't miss the point that the diabetic, hypertensive, and lipid status is under control. So when you're consenting such a patient, you can confidently tell them that with anti-VEGF treatment, there is definite improvement in vision. Without treatment, there will be gradual deterioration of vision. It's not like AMD where there's a sudden change to patient's vision. The diabetic hypertensive control has to be maintained. 95% of the patients won't deteriorate over the 2-year period of treatment. You can give this figure of 40 to 50% chance of 2 lines improvement, or more than 30% chance of 3-line improvement in vision. Also, there has to be commitment towards the long-term treatment in terms of attendance. Also, 1 in 3,000 risk of endophthalmitis, and the cumulative risk is much higher. Also, diabetic patients, they have a systemic problem. So although there are no safety concerns as yet, but you have to bear that in mind. In terms of the regimen, how we treat the patients, so we start treating them with monthly injections till the fovea is dry. Continue treatment until you have 3 consecutive stable vision. You can, after that, go on to like a treat and extend strategy to maintain that level of vision, which is about 5 letters of the best ever vision you have retained. And then what you try to do is in the first year, towards the end of first year, you're trying to go to about 6 to 8 weekly injections. And in the second year, towards the end of second year, you are somewhere around 10 to 12 weekly injections. And you can safely extend them 1 to 2 weeks at a time. Early recurrences. Now, most of patients who are having treatment with anti-VEGF injections, what you realize is they are pretty good in judging and actually guiding you when their edema reoccurs. And that will determine what should be the interval between the injections. So in terms of patients who have early recurrences, you can consider reducing the interval by 2 weeks. If there's a very early recurrence, which is unusual, you have to question how's the patient's systemic control. When to stop? There are no definite rules. We are still learning from all this experience. And maybe as a first off, when you're starting the patient on treatment, if you have gone down and into the second year or maybe third year, where you have 2 consecutive periods of 3 months interval, so about 6 months goes without treating, then you can consider stopping injections. I'll skip through the case. So just to summarize, patients, now we have moved to an era of anti-VEGF therapy where the most significant advance, it's the most significant advance in terms of treating diabetic macular edema over the last 50 years. And the first therapy is likely to improve the vision and almost certainly to stabilize the vision. Repeated intravitreal injections and prolonged therapy over at least 3 years. There is a role of steroids, and steroids will have a role in patients who are pseudophakes or who have chronic macular edema not responding to anti-VEGF. The long-term effect of laser still needs to be determined in patients with central involving macular edema. The challenges are in terms of monitoring these patients and implementing it for us in the UK. And down the line, I'm sure there will be new agents which will make our life easier. Thank you very much.